Welcome to the Hit Like a Girl podcast, where with each episode we hear from different women experts in the health IT industry.
We like to hear about what makes them tick, how they overcome challenges, work they're proud of, advice they would give to other women in health IT, and much more.
I'm Joy Rios.
And I'm Robin Roberts.
Don't you hate it when technology gets too technical? We do. So we're thrilled that Raychelle Fernendez, Vice President of Dynamic Health IT, is talking us through the mechanisms for sharing information in healthcare, both past, present, and future. Interoperability is all the rage this year, and Raychelle simplifies what's going on and how she's working to help others understand and work towards trusted sharing of information.
Absolutely. I have a quote and I use it. I don't know whose it was, but I always tell everyone that comes to work on our team that if you're the smartest person in the room, you're not in the right room, because everyone needs to learn from someone else. And I've always taken that philosophy that, if I'm at a place where I feel like I know everything, then I need to move somewhere else. I need to broaden my horizons, open the door for other opportunities so that I'm learning still. And even when you know it all, someone else knows it differently. So
it's so true. It's true.
Our entire team is told that the day they're hired, before they're hired actually, to let them know that you're going to learn something from anyone. The intermediate developer is going to teach the lead developer something at some point. QA is always going to have a different way of looking at a task. And that's just been my motto since college, that I will definitely find that avenue I need to find to make sure I'm not feeling like I'm the smartest person in the room. The other part of that is, even if you know it all, which nobody knows it all, but if you feel like you know it all, you're going to learn it differently from someone else. And in that process, you'll learn something new. I came into healthcare IT, a headhunter pushed me this way. I'm older than you might think, but my first experience with computer science was on a Tandy 1000 TL2 computer. I had a professor, a teacher that was a male, and he said, why don't you, here's my program. I want you to repeat the program, basically copy my code, and you're going to end up with a spaceship, a little asteroid type of spaceship that you would see in the game Asteroid on screen. Okay, cool. So we had 4 girls in this computer science class. It was an elective. We picked to take it. I was in an all-girl Catholic school at the time, and at that I was able to create the spaceship, also make it take off, and change colors while it lifted off. I thought I had found my calling. I was going to be a programmer for the rest of my life, and that's what I wanted to do. Went to college, and it just wasn't there for me. The industry wasn't as accepting of females. I would have been the one of 150 students, and I didn't feel like I had the confidence to continue. So I went into accounting, and I became an accountant. From that point on, I ended up doing accounting in companies and moving their ledgers and journals into computer systems using QuadraPro or QuickBooks. QuickBooks didn't exist at the time. So we used QuadraPro, then we used Excel, and I was like, look, you don't need me anymore. There's this great program. You just have to send me your files, end of the year, and I will handle your taxes for you. So my concept of bringing things from paper to computer systems was all accounting based. It was numbers. It all made sense. Everything had a number and account. So I got a little bored. I worked for a health and wellness center in New Orleans. It was franchised. We had about 7 locations, and Katrina hit. And my job was to handle disaster recovery for the stores. It was not that difficult. Once the internet was up and everything was working, we had all stores running again. From that point on, I felt like I wasn't really doing what I wanted to be doing any longer. Katrina just kind of opened a lot of people's eyes and closed a lot of doors for a lot of people. In that process, I started hearing, I don't know if y'all are aware of, I'm sure you are, of the industry because of Karen DeSalvo and what happened to Katrina in the healthcare industry and the way we suffered here and patients suffered, as well as nurses and doctors through the process. And I just felt like it was interesting, but I didn't know where I fit in. So I reached out to a headhunter, and she says, look, you need to go in healthcare IT. She says, you have the skills, you have what you're talking the things that people in the industry are talking about. And Katrina gave me a good in because there was devastation here and we needed to figure out a better way to do processes. I came to work for a healthcare IT company in New Orleans that had no New Orleans customers. It wasn't the realm that we were in. All of our customers were nationwide, and I think we had one customer in Slidell. But I started doing interface engine work, and I was hands-in. I said, teach me, show me. And at the same time, I did some, office management overseeing of the administration team. Got very comfortable in the healthcare IT interface engine, V2, HL7 messages. And from there, it kind of grew. From that point on, we had CCDAs, V3 of the data elements and documents that were being shared. And now, of course, FHIR. So that's where we are today. That's kind of my little story about how I got here. And no, I am not clinical in any way, but I know a lot about clinical terms because of my job, as well as being a mother. Being a mom, we're the caregiver for our children, our husbands, our parents. A lot of people would ask me when I was in the hospital, are you a nurse? And I'm like, nope, I'm just a mom. And then I realized, I really discounted that by saying just a mom. There's so many things that a mother's intuitions and things she brings to the job helps her every day with, multitasking and organization and just getting things done timely, because you're always on someone else's schedule, normally if you're a mom.
Raychelle, I want to stop you for a moment, because here you are saying of, how much stuff that being very humble about things that you don't know, but you just rattled off HL7, FHIR, and CCDA, which is, upper level health IT stuff. So for those who don't know, and maybe, for folks that are not aware of the acronym soup, could you take a minute to kind of talk about maybe those three and what they actually mean for a layperson?
Absolutely. So HL7 is health level 7. It's the 7th level of healthcare. And in that standard, there are message structures that are required. So if a patient comes into the hospital, they are automatically triggered in an electronic medical record, a message that will produce an admit message. And that message has a structure. And in that structure, you're getting the patient demographics, you're getting the patient visit information, you get the doctor information, you get their next of kin. So that message, and sometimes there's allergies in ADT. So that ADT message structure was very defined, and certain information can be transferred through that. There's also order messages and result messages for labs and radiology. There's allergy messages, there's immunization messages. So in the background of when a patient comes in, even before meaningful use, there was the concept, or promoting interoperability now, but there was the concept of data is being transferred within that environment. And if you were lucky, the message was going out to the lab system to let the lab system know the patient had an order. And if the lab system was across the street, they might have had a connection across the street to send that lab message, so that when you got there with your lab order in hand, they also had the lab order in the computer system. And it was more of a verification process. So that's what V2 allowed. It allowed the transmission through interface engine, which is pretty much tunnels from place to place that deliver the messages that are coming from registration or pharmacy or, like I said, our lab system. That's V2. From there, the industry decided there's not enough. We're not hitting all the cases with the data delivery that's occurring. So we should move to V3. And in the United States, we did CCDA. A CCDA document is an XML format, and I'm throwing out another code, more acronyms out there, but the XML document is a certain structure. It looks nothing like a V2 message. It's longitudinal. It can go across care continuum, whereas an HL7 V2 message is just a staple in time. So then you ended up with these really large documents that doctors were having to produce because of meaningful use to send out to other clinicians to transition a patient. So that's the CCDA. The purpose of the CCDA is to give the patient a snapshot of their information in a document that's human readable, as well as to transfer a patient to another doctor with a human readable document. So that's all working great. Maybe not, because the doctors are very upset. We're very upset that, why are you sending me all this garbage, with quotes from many doctors. Where do I find the information I need? How do I find out what lab result they had, 3 months ago, when I have 500 labs in front of me for one patient? So the brain team, as I like to call them at HL7, Graham Greaves is one of the leaders there. He's called like Fire Chief, came up with FIRE with his team. And so the FAST information resource was born at that point and continues to emerge. Right now we're on version 4 for certification. We implemented version 3. Orgonaut project, you've probably heard the words of Orgonaut. They use Smart on Fire, and that's version 2. The Apple Health Kit reads in version 2 at this point of FIRE. And patients can see their data in the Apple Health Kit. If their vendor or the hospital they happen to go to and have a medical record at has a FIRE API that hooks up to Apple Health Kit, they can then get their data in their phone.
And usually when it's that kind of data, it's not the complete picture of their care, but actually targeted pieces of their health record that like kind of what they need, the information they need at that specific time, instead of giving them everything. Okay.
That's exactly right. So we have patient portal. I mean, if you go to your ENT, you have a patient portal. If you go to your general practitioner, you have a patient portal. If you're lucky, you're under, a bigger system where you might not have to go to so many different portals. The concept of FIRE was to give the information in pieces, or the full document if you care for it, but to give the information in the different sections of care that you need. So if I need my child's immunization for the last year, then I'm able to request the immunization. I don't have to have all the lab results if I don't want them. This allows patients to share their data, if they choose to a study. Say I have a cancer patient and they'd like to share their data for maybe Sync for Science, one of the programs that's out there. They would be able to share their data from their phone and have control of that data. They can determine, I don't want to download any of my lab results. I'd rather just have my medications in my phone because I want an active record of my medications. So they can choose to just have those medications in their system, or choose to just share their medications and not share their lab results.
Raychelle, you brought up something a little bit ago about being a mom as a consumer of healthcare, both for yourself, your kids, your family. And so the Argonaut project on FIRE is specifically connected to Boston Children's, right?
Yes.
And so as you think about being a mom and really where we started so many years ago, these standards, building consensus to get more streamlined standards, giving people relevant information, not just throwing up the whole record to the doctor and really having them probably more lost than they were to begin with. Where do you see this going, and what kind of benefit do you think we'll see as a result of projects like Argonaut with using Smart on Fire, specifically Boston Children's and those parents? How does that have you feeling, I guess, both professionally about the evolution of things and where they're headed, and maybe even personally in the benefits, and still maybe where we have to go into the future for people to really realize the value as, a parent?
Absolutely. It's all, I think most of it is education. People need to know that they have their health record available and it's supposed to be provided to them. We need the public to come up, and the developers and the innovators to come up with platforms that allow patients to easily get their information. I, as a parent and an evacuee from Hurricane Katrina, happened to grab the folder of my kids' immunizations when I grabbed my health insurance and my home insurance. So I had my kids' immunization records when I evacuated on paper. When I got there, the first thing I had to do was get my kids in school because I couldn't return home. And I had the paper, but so many parents didn't. And you don't want to have your kids revaccinated. Of course, the government comes up with a plan and handles that type of situation. But my kids were in school 2 days after I realized I couldn't return home, which was about 3 days after Katrina. Those type of things, being able to pull my children's immunization records while I'm at home, that first week school starts and I just need to, give them the most recent immunization records. I could just pull that up on my phone and fill out the documentation, or better yet, send it, out in an email to the school and say, here's their records, it's updated. That to me is, the simple things. Let's do the simple things first. Can I see my child's growth chart on my phone? How do I check to see what my lab results were without having to wait for the doctor to actually review and get back to me when I missed his call last time? Those type of things I think can be done immediately. My concern is interoperability. I attend all the connectathons that are in state. I'm in the United States. I don't travel abroad for the most part, but we've been going to them from the onset of fire. And Ozlem was one of my developers here, and I were the only females in the room for the first one that we attended. And, it's grown and there's more people attending, there's more females there, but, that concept of everyone's doing this, and now everyone's required to do fire if they want to be ONC certified. Are we going to be interoperable? Are we creating the same problems we already have? And I say that because a resource for something like lab results can be done so many different ways. And if you're not going to the connectathons and the EMR systems are not collaborating, we're going to have interoperability nightmare on our hands. There's a call for everyone to start testing against the ONC APIs. I'm not one to advocate for more government in any way, but there does have to be standards, and there's 3 stages to interoperability. And in that process, we need to be hitting them. And if we don't hit the 3 stages of interoperability, we're going to run into troubles with being interoperable.
Could you speak to the three stages of interoperability, what they are and where you think we are, or where are we?
Sure. So level 1 is the lowest level, and it's functional. The first level of interoperability involves basic standards. We have the basic standards now. We now have HL7 fire normative. We're going to be it's going to be backwards compatible from this point forward. So with that being said, and HL7 and ONC agreeing on the standard, level 1 has been accomplished. Once the EMR systems take that on, there's several EMR systems that didn't go with fire for the API. That's a problem because now they have people using those APIs and they need to now use fire for that. So they will have to make that transition. Level 2 is structure. At that point, the data can be interpreted. So when you receive the structured data, does it remain consistent? That's a challenge because of this thing I stated before, is the structure is there, but is everybody doing the same structure? If you take PHRs, which is the patient health records, or PMRs, patient medical records, these are apps that are supposed to be on people's phones. There's developers out there creating them. If that PHR tries to hook up to, let's say, Connect PHRs, our dynamic fire that a company I work for offers. If we take dynamic fire and we connect to it, can Epic then connect to that same PHR using the same resources? Or we build in individual interfaces again to a PHR? That's the question. I think that's out there right now. That second, the intermediate level, is the structure consistent? And does it remain consistent? And yes, the standard could be, but are the implementers doing their part to make sure that they're interoperable? And are they attending the connectathons or the implementations and making sure that they can work with these teams and work with other systems? And the third level is more about the solution. Will we be able to exchange information? Healthcare information systems will be able to exchange and interpret and use the data. The use of the data is going to be easier for the patient because Apple has stepped up and they're going to give the data. People will follow. Systems will follow. Android's going to have, something equivalent to that, or already does have something equivalent to that. That's going to happen for the patients, but the clinicians will not and they're supposed to. They're not comfortable. They don't trust the data coming from other systems. And so reconciling someone else's document or resource into your system seems to be a struggle. And it's because of trust. It's because of liability. It's because there's no provenance. And provenance is the ability to know who and when something was done or who owns it for auditing purposes. And with that, that it's coming. It's part of the proposed rule from ONC is to ensure that every exchange of data has a provenance, so you know who's responsible for that information. I think once we have that, then we'll be okay, and doctors will start trusting the information. But with ONC 2015 edition CCDAs, there's a reconciliation requirement to pull data in and reconcile problems, medication, and medication allergies. And that data is supposed to be pulled into the system and made part of the health record. There's not many EMR systems that are using that functionality. Yes, they're certified on it. Yes, it exists. But if I am transitioned from my primary care doctor to my ENT, he should get a transition of care document, and he should pull that into his system so he already knows what my medications are or my allergies. But they're not doing it. It's not happening. They might be reading the PDF so that they know a little bit about it, and they can talk to me and ask me questions from the PDF, but they're not pulling that data in because they don't trust it. It's the theory I have at this point.
Raychelle, you have done such a beautiful job explaining things so simply, and you touched on another very important word. So I'm going one layer deeper into this onion or this rabbit hole we're in. It's going to get a little bit darker. You touched on an important word, which is provenance. So talk to me about where blockchain now is coming on the scene to help be that verification. And I guess maybe if you can bring it full circle from on everything, the evolution of what you've walked all of our listeners through. Talk to me about where blockchain fits and tell me what this whole thing looks like in 3 or 5 years from where you sit.
Okay, so I looked into blockchain as the buzzword last year before HIMSS, trying to get enough information so I felt like I knew what my questions were that I was going to ask and who did I need to talk to. It was way too soon. This year, it's coming around. I'm not following it as closely as other members of my team are at this point, but we need to have an answer to the patient ID. We need to know who patients are. And can blockchain offer that? If it's not a national registry of patients, I don't know how that happens. I'm still skeptical. I do know that people are using blockchain. I do hear it out there. I see companies. I know there's EMR systems that run on blockchain, but it's still a silo. They're still isolated. It's private blockchain. It's not a, like I said, national or global type of blockchain. I don't know. I'm still skeptical. I wish I could say that we're not implementing it where I am at this point. We have talked to several companies that bring it to the table. I do think it could be a help for fire, but OpenID and OAuth is the process at this point, and everyone's using it. So where does blockchain fit into that? I'm not sure, but I do know a very good part of blockchain in the industry is with audit logs, and keeping track of the transactions for the audit logs seems to be ideal at this point.
You know, I couldn't agree with you more because, correct me if I'm wrong, but we can audit it all we want, but that singular patient identifier to make sure we have the same singular patient on that longitudinal record over time, exchanging hands for just the right information, but the provenance and the validity to all of those exchanges being verified for a singular individual is really critical to success, right? Because Suzanne Adams can show up, and if tomorrow someone at the front desk, an entry-level employee, a new registrar enters her as Sue Adams or Susan versus Suzanne, we will never crack that nut entirely on patient match, especially if the patient moves. It's just impossible.
That's exactly right.
Thank you very much. We talked to a really big organization at a conference we were at the other week, and he said, I said, talk to me about patient match and this data lake they had built. And I didn't really care about it in terms of all of the feeds they had brought together in resolving those disparities, but the ongoing challenge of not having a single unifier. And so I'm so glad you brought that up. So Joy, do you want to take our next question?
Sure. I have a feeling, I have an inkling of where you might answer, but I think it's, let's find out. If you could snap your fingers, put on your magical utopian hat, and have any problem within health IT solved, what would it be and why?
Well, you know what I'm going to say, I think, now because of where this conversation went, but trust and development of your unique patient identifier that would protect the patient and foster interoperability without fears of socialism or communism. There's got to be an answer. We need to do this. I need to know that Mary Grant across the street is the same Mary Grant that I just saw 5 minutes ago. Yes, it'd be great nationally, but can we do it just across the street first? Can we do it in the same EMR system? I might have 3 different patient IDs in the same EMR system. They have systems that use master patient index and match these patients. Not everyone's using a master patient index. I work on interoperability and interface engines and getting people's CCDAs every day, and my hands get really dirty with it, and it's not happening. And patient matching is a must. And then identifying that patient consistently post the matching across the nation, across the globe is a major hurdle. I call it the white elephant in the room because for years, because I came in the industry outside of healthcare, and my first thing was, well, how do I identify, I'm thinking account numbers, right? How do I identify a patient? And they tell you, well, you could use this, you can use this, but basically there's a medical record number in the record. Okay, well, what about Social Security? We can't use that. And there's so many identifiers that we have for ourselves already. We have Social Security numbers, we have passport IDs, we have checking account numbers, we have your credit score, you can get that. There's ways that Americans and people across the globe are being identified. Why not a healthcare ID? Well, because we're scared and we don't trust. So how do we get the trust? And if we can get the trust, then we can and protect us and know that insurance companies aren't going to drop us because we have certain, and that's kind of been set up now because pre-existing conditions are allowed. So how do we foresee that coming to the future? I wish I could snap my fingers, make it happen.
That we've heard quite a few others say something similar, and no one yet has brought up, the fear-based aspect of it, where, ultimately, like the fear is, we're headed towards socialism or communism by having that identifier, and that's just kind of nuts, especially when you think about like all the other individual numbers that you can be tracked by.
I mean, think about just your cell phone in general. And if you have your location finder on, or if you're taking pictures and you didn't turn off your location finder, everything's out there. It's being able to protect ourselves and trust the systems that we sign into. And so the structure needs to be provided. The government's not going to do it at this point because of Congress. And it's been said that it's going to have to be the private sector handling coming up with this identifier.
It's kind of crazy that we've created this system where we're, cutting off our nose to spite our face a bit. But
yes.
Transitioning to our third question, we are building a reading list. So we'd like to be able to accelerate learning for the Hit Like a Girl pod listeners. And so if there are any books that have been impactful to you, either personally or professionally, that you think others would benefit from reading, can you speak to what those are?
Yes. So when you said books, so it was kind of tricky because I don't read a lot of books, but I read a lot of blogs because healthcare IT changes daily. It's dynamic. It's ever changing. So I read lots of blogs to make sure that I'm understanding what the industry is saying. So HL7 International Standards, Health Intersections, Code Girl, the things in the industry that I know. There, healthcare scenes with Jim Tate provides information there. I stay up to date there. I listen to podcasts, but really for a book, if I had to pick a book, because that's your question, and we write our own blog here as well. But for a book itself, I'm going to go with a really simple one, and it's The Fish Philosophy. It's called The Fish Book, and it has nothing immediately to do with healthcare IT. It's a very short read. It talks about choosing your attitude, play, enjoy, and use humor in every situation possible. Make their day is a big chapter in it where it talks about having memorable experiences. We are in a service industry. We are offering services to EHRs, to patients, to providers, and we need to make sure that you're making a difference and you're not wasting people's time. The last thing is be present and fully engaged in your work. If you're not happy, then you're in the wrong place. And it didn't take me long to learn that. I had 2 female mentors at my prior company before coming to healthcare IT, and they recognized that I needed something different. Now, they would have kept me on forever, but they said, you're bored and you need more, and it's time for you to make that leap. And they fostered me and engaged me in, where do you want to go? Talk to me about getting a headhunter. So that book we read as a company at the prior company, and everybody read it because it was, I think, maybe 50, 60 pages. But it gives you an insight. It's about a company, it's about a fish market in Seattle. And they go to work every day and they clean fish and they catch fish and they sell fish, but their attitude is amazing. And so that's my book. There was some other books like Nice Girls Don't Get the Corner Office. Really good book for a female going into an industry with mostly male on the IT side. That's one other one I have. And I just want to mention one other one, The Confidence Code. If you're raising daughters, read this book. It's going to help you tell your tweens how to make sure that if you're called bossy, it's okay. If you are experiencing issues with being different, because maybe you are more technical. Maybe you look at things differently than a lot of your friends do. And I say this because I have a 12-year-old and a 22-year-old. And they both are one's in engineering at Louisiana Tech. The other one is still in elementary school, but struggles with, she loves riding horses. She loves biology. She loves science. She loves chemistry, and she likes computers. And she just doesn't fit in all the time. And this book has really helped me as a parent to, talk to her about why is she a little bit different, and that it's okay. And eventually she's going to get into an industry or in a situation where she's very comfortable. So things like STEM, she does some STEM during the summer to ensure that she's engaged with children that enjoy the same things she does.
Those are all great suggestions. And don't feel like you can't say blogs, because blogs count as reading too. Okay,
that they do for me. I read blogs all the time. I mean, daily I read blogs always, because that's where you're finding out that the collaboration happens. And you can comment on the blogs and get more information. And LinkedIn, of course.
Raychelle, if our listeners want to find out more about you or your organization, what's the best way to find you online?
Okay, I am on LinkedIn at Raychelle Fernendez. That's the best way to find me at this point. And we also have a blog that I oversee and put my 2 cents into regularly, which is at Dynamic Health IT.
It's great to speak with you, Raychelle, and thank you so much for all your feedback. Thank you for breaking down some very technical things and making them simple for our listeners. And we always appreciate being able to learn from other people. That's part of the reason we started this. And so that and standing out in your field, the advice you gave us there at the end and what you share with your own children and how you approach work is just awesome and spot on. So thank you so much for speaking with us.
And thank you for listening to the Hit Like a Girl podcast. If you want to know more about us or this guest, check out our website at hitlikeagirlpod.com.
While you're at it, if you found value in this episode, we'd appreciate a ratings on iTunes, or simply tell a friend. You can also connect with us on Twitter or Instagram at the handle HitLikeAGirlPod. Thanks again. See you soon.